The global Covid-19 pandemic is overstretching health systems. Essential health services, immunization, reproductive health services have all been impacted. Now, mitigating the continued impact of the pandemic on sexual and reproductive health services is going to need concerted action. In the next few minutes, we're going to turn to our experts to understand how we can all proceed from here. Where do the solutions lie? Dr. Nozer Shehryar, an obstetrician and gynecologist, also the former Secretary General of FOXI, will speak on things we need to do differently from now on. Manoj Manning, who's the Chief Executive Officer of the IPAS Development Foundation, will speak on steps to improve women's access. Shankar Narayanan, the Managing Director of PSI India Private Limited, will speak on accelerating the model of self-care when it comes to sexual and reproductive health and rights. Lisa Mangaldas on simple awareness. Anubha Rastogi is a lawyer and she'll be speaking on the language of justice. And finally, Anjali Nair, the Executive Vice President of Global Health Strategies, on always listening to the woman, asking her what she needs, and then providing for it.
So in the next few months, if I had to do something, I would show, they say, don't waste a crisis. It's become such a cliche thing. We've done things differently in these 2 or 3 months. We need to carry this forward. And the other. The second thing I'd love to see, we are suddenly being asked to go for telemedicine in a big way. 4 months, we were told by the Medical Council of India and the IMA that don't you dare go for telemedicine because you haven't seen the patient. We are seeing here that telemedicine is not only possible, it's now being promoted. And I believe most reproductive health care is very telemedicine sensitive and practical because contraception, advice can be given. Today, access can be online access. You can order things online. You can go and get it close by. With abortions, as of now, we think that may not be possible. Anubha is here, but I've read and I've read and I've read the Act. The Act was written in 1971. We were not even dreaming about where we are today. Maybe it's time for us to push and say, if you can do an assessment, if you can do a counseling, if she can access a medication, if she can sign that one form online, why can't we take abortion access to telemedicine? The reality is the country needs it, the world needs it. 56 million abortions worldwide, 15.6 million abortions in India. You don't have the services to take care of these people. We have to go and think out of the box now. And let's push. What saddens me is most of this conversation has been happening amongst us. I want women's group to come forward and demand it. I want other groups who look after women's reproductive rights to come and demand it and not make it look like it's a few providers and a few people who kind of champion this issue, who keep coming back to it.
Yes, the key question I think is what do we need to prepare for and probably look at it long time and immediately. So some of the immediate steps, and I think it's extremely critical, is this movement of, these 1.85 million women, a large part of them in normal course would have had abortions, self-managed abortion or done abortions within themselves. Now a large part of them, because they have moved beyond that 9-week cutoff period, will need to access facilities, which even at normal times have been a challenge. So we need to take steps to make sure that they're able to reach facilities. So which would mean a couple of things. A good mapping of all the facilities available, both in the public, in the private sector, and make that information available right now. Today, a woman comes into a PHC, even if the PHC is not able to provide services, which is possible because, as Dr. Nozer said, we don't have enough providers because our law is like that. So that's a long-term change, and I hope it will happen sometime. But till then, at least the provider should have that enough information to provide counseling and referral services to a facility close by. Then the second thing is then you've got the other lot who would move into second trimester. India historically has been extremely poor at providing second trimester abortions. And from access perspective, from that conflation that Anubha Rastogi talked about, the sex selection and So we need to make sure that we preserve those facilities that are currently providing second trimester abortion and enable them to provide it to a larger number of women who come in. So these are some of the tactical short-term measures I think we need to immediately swing into action.
I think, number one, we have to accelerate progress for self-care in SRHR. I think that's the mental model we need to have of how do we accelerate self-care if you want the choice and the access to be hers, the decision to be hers. And so when choice and access are constrained, then agency, which was not great to start with in India, is going to be severely constrained. So if your framework going forward for market functions, for support functions, for rules and regulations have to be geared towards self-care. Grim as it may sound, lockdown and epidemics are going to be inevitable, right? So how do we take all the learnings? We now know from Ebola, Zika, SARS, the deep and long-lasting effect it has on gender equality. So we can't say we didn't know that. We knew that coronavirus and a pandemic like this will come, yet we didn't. So one of the things that I want to build upon what Vinod was saying was, in the short and medium term, how do we ensure that high quality supplies are being made and then have supportive and rules functions supporting access and quality for essential medicines, SRHR and abortion specifically. Second, I think accelerate the progress towards self-care. That's where I think telemedicine and teleconsultation and door delivery of drugs are involved. And how do you ensure that regulations and rules move around self-care?
Yeah, I just want to say that I hope it is a priority to not just during or in the context of the lockdown, but in general, to educate women about things like contraception and even just the body, because I find, and again, I'm saying we're a privileged section that's accessing my content, educated, et cetera, but I am just amazed at how dismal the overall understanding of even basic anatomy is. I mean, most young women in the age of, let's say, 16 to 35, might not even really know what ovulation means, or might not realize that they don't urinate from the same hole that they menstruate from. You know, I mean, I saw on the IPAS website that these beautiful sessions that seem to take place in villages with community leaders, and there's, you know, a circle of women and men looking at a diagram of the vulva, naming the parts and all of this. When does that ever happen in a middle class or upper middle class setting? It's not happening at home. It's not happening at school. No NGO is coming to your door. And so, I mean, while it's ridiculous to have all the access and still not know, but that is the state of affairs. Whereas a woman like me, I have the resources, the money, access to the chemist, et cetera, but nobody would have ever talked to me about my own body. I wouldn't feel I mean, I'm not me particularly, because I've gone out of my way to get comfortable with all of this, but I'm just saying friends of mine or anyone else in even the same circle of privilege would struggle to even know what they should be reaching out for if they had a pregnancy scare.
Yeah, I think the final bottom line really needs to be that the decision making needs to be in the hand of the pregnant person. And to ensure that is facilitated, everything should center around that. So that she or the pregnant person has access to information when they want it. They are able to access the services that they need at that point in time. They are able to make a decision, because, you know, these are not simple decisions. This is not just something that you wake up and say, okay, today I'm going to do this. There is a lot of back and forth that happens. I mean, everyone knows that either from personal experience or from experiences of dealing with patients of this nature. So I think, and the access has to be in a manner which will ensure that a pregnant person anywhere in the country is able to use that. So whether that's in terms of language, it's in terms of technology, it's in terms of ensuring there's no stigma, no prejudice, and that the service is accessible, whether it's down the lane or it's in the private hospital, public hospital, wherever. I think that that's the bottom line for me.
The one big challenge that I think that will continue is, even if, even when the amendments are passed in whatever shape or form, the one big challenge that will continue, how do we get the information out to the woman at the village level? And how do we make sure that there is no stigma? So, in a country where the word sex in itself gets stigmatized to even talk about abortion, or even give that woman the agency to decide that she does not want to get pregnant, or it's an unintended pregnancy, or whatever the reasons are for her to get an abortion, to know that it's legal, that it can be safe, there can be confidentiality, and there is someone she can reach out to get that information. I think if we can get those 4 things sorted out, that will make all the difference in the world. At the end of it, we have to listen to the woman. Right from the time I started, even when we were looking at bringing injectables, emergency contraception, then injectables into the system, we were constantly fighting, and the refrain from all women's health advocates across the globe was listen to the woman, ask her what she needs, and then provide it.